Thank you, friend. Okay. Bear with me while I share my slides. So welcome to the 2023 iteration of the LGBTQIA plus NRT, which we actually call a learning collaborative versus an NRT. And what I'd like to do is just kind of go through initially the history and background of where we got to where we're at today briefly, because I know we have some new folks who maybe haven't joined us before. And our intention in this relaunch, which was very strategic and deliberate, was to pivot to using the space to our advantage and to the community's needs and desires of our time together here. So 2 housekeeping items. The session is being recorded. And as I already mentioned earlier, please add your personal pronouns to your Zoom name. You can do that by hovering over your video box on Zoom and pressing the button that has 3 little dots at the top and hitting rename. So if you've never joined us before, this learning collaborative is an initiative between the American Institute of Dental Public Health and the Oral Health Progress and Equity Network. So AIDPH has been the facilitator of this collaborative since 2020, and it's been part of this open sort of design and framework of having what we've called in the past network response teams, because open is a network of oral health stakeholders from all different types of community, state, and federal level organizations and individuals. And as part of what these were originally designed to be, the network, these learning collaboratives and teams were designed to support the network. They were designed to create, to amplify health equity opportunities, resources, kind of calls to action, etc., for the Oral Health Progress and Equity Network. We recognize in the past that that has been a bit confusing, especially if you're joining us for the first time, may not really understand open, maybe never have participated in anything related to open before, but this is something that you're interested in doing now. We really like to reframe this, this monthly, which we're now shifting to quarterly. We really like to reframe this as a learning collaborative with hopefully applied action items. So one change, which is why we paused activities for a time and are now relaunching, is that Open used to have what they would call a backbone organization, which was essentially administrative support with a national network for public health institutes. There we go, NMPHI. At this point, Open has shifted away from using NMPHI and is now managed with CareQuest Institute for Oral Health as the backbone organization. And with that has come some minor changes, restructures. Like any change takes a bit of time. And so we now feel really excited to relaunch, knowing that there's a dedicated backbone for administrative support. And Frances, while she's on the call, is our representative from CareQuest, who helps facilitate these meetings in collaboration with AIDPH and this learning collaborative. So Frances, is there anything else that I may have missed that you feel is important for us to talk about in this space of the connection between Open and CareQuest and what these learning collaboratives or NRTs should be doing moving forward?
No, I think you did a great job summarizing, and more people in the waiting room. Hold on just a second. Unless there's any questions, I think that's.
Okay. Hearing none. I wanted to give a little bit of information also about why this is important to AIDPH. AIDPH has what we call 4 core communities of focus, which is rural oral health, veteran oral health, LGBTQIA oral health, and a 4th that is not represented here because we're still fleshing out what our work plan looks like, but a dedicated intention to work with individuals with disabilities. And I mention that because some of the things that this Learning and Action Collaborative can address, if desired, is, how LGBTQIA oral health may even intersect with some of those areas. So for instance, AIDPH works with LGBTQIA veterans and supporting and promoting their oral health. So AIDPH has resources and intention to move this forward. We would be doing this work regardless of whether or not Open gave us a platform to do this, because this is critically important to us as part of our core communities. And we're really lucky that we get to serve as the facilitator for this learning collaborative. Okay. So I normally don't like to do the history of anything, because that feels sometimes unexciting. I won't say boring, but I get that sometimes it's not the most fun thing to review. However, in setting us up for discussion and how we want to move forward together this year and community with each other, I actually thought it was important for us to be grounded in the work that we've done previously and discuss opportunities for us to elongate that work, to go deeper into some of our work if desired, and pardon me. Or do something completely different if what we were doing before is not of interest to this new group. So as I mentioned, for this learning collaborative, we began in 2020. And that was because, these affinity groups within Open sort of popped up around areas of interest that were driven by the network. We have other affinity groups too, like rural oral health. There's a Native American network for oral health, a policy learning collaborative, etc. And all of those sort of fall under the umbrella of health equity and oral health. And so when network members were looking around, and Steve Geierman, I know you're one of them, he and I were discussing that there really wasn't any affinity groups or focus areas on LGBTQIA oral health, which is why we began this focus in 2020. And the first thing that we did was actually ask our community, what do we need? What do you want? What should we focus on? So that it could really be community driven and informed. And so from that, we designed our purpose and goals with the intention of really bringing cross-cutting network awareness to LGBTQIA oral health. In 2021, we heard pretty clearly that what our community desired was an understanding of policies and how we could potentially dive into that as a learning collaborative, how we could amplify education through webinars and workshops, and then advocate for more equitable oral health for the LGBTQIA community. And so we sort of shifted from trying to understand what the community wanted to actually implementing what we heard via those resources. Last year, AIDPH was able to scale and grow and come up with a more dedicated and deliberate path forwards to supporting LGBTQIA oral health. And through that, we've actually been able to draw in members from this learning collaborative to help inform things like the LGBTQIA Oral Health Week, to ensure things like when we're designing surveys, that they are reviewed by the community, informed by the community, and that we're implementing things in best practice with the intention to serve our community. And then now in 2023, after this restructure between Open and CareQuest, we are looking to all of you to say, what should we be focused on this year? We have some ideas, we have some opportunities to discuss, but we don't know what we don't know. And because our intention is to re-engage after a time of stepping away and allowing things to sort of settle, we would really enjoy hearing more about how we could use any of the things that we've done in the past, again, to facilitate this moving forward, or say that didn't really serve us and this is where we need to pivot. I gave some examples here of some of the things that the NRT has done in the past, or the Learning Collaborative has done in the past. You may not have known that this is some of the work that we've done, but we actually have developed resources on LGBTQIA oral health equity, really easy things that oral health professionals can do right now to expedite and facilitate oral health equity among LGBTQIA plus people. Easy things like what we're doing here today, which is, ensuring that our personal pronouns are front and center. And, even guides to clinical spaces and how clinical care can be supportive for LGBTQIA plus people, all the way to policy advocacy and primers for advocating on policies that have been offered at the federal level. We haven't really done that at the state level, but as opportunities arise, some things that the group has done is create toolkits to be able to advocate on those policies. And then, as I mentioned, in October of last year, and now every year moving forward, we will host the LGBTQIA plus Oral Health Week, where we really spend a week delving into important topics that were frankly defined by this group and this learning collaborative on what we should be moving forward with to educate, advocate, and amplify the needs of the LGBTQIA community. So in years past, as I mentioned, we've done monthly meetings. We've really done a lot of advocacy and education campaigns. We've also identified community leadership. Our intention and our hope is to actually lead from behind in this particular issue. Our desire is to identify community leaders who want to help this education piece, who have expertise and knowledge that we can serve as a platform for you to be able to share your information, and for AIDPH and Open to sort of take a back seat in terms of the leadership. We also use the space for personal and professional growth. And this year, we are switching things in that we are no longer doing monthly meetings. We heard from our community that that was too much to keep up with, and that really quarterly meetings that were maybe a bit longer, like this one, it's an hour and a half, so that we could do those things like personal and professional growth, but not have to do that every month where it feels daunting, especially if we're talking about policies at the state level in particular. Sometimes that can be a really challenging thing to be reminded about every month, particularly in this political climate. So our shift here is, to offer this framework again for this 2023 Learning Collaborative with the opportunity to shift it, which is something that we'll discuss here on this call. This is a draft of our current purpose and goals. It has not changed much. And based on feedback from the community, these have served us well in the past. But every year we like to revisit them and say, does this still align with our objectives and what this initiative would like to accomplish each year? So really, it's about identifying and amplifying resources, developing strategies to engage on LGBTQIA oral health, and then also when we have information to be able to disseminate it in a timely manner. So what I'd like to do, I'm going to stop sharing. And what I'd like to do is, in the vein of using this space for personal and professional growth, expanding our network and ensuring that everybody has a voice as we talk about this important topic, I'd like to, I'm seeing how many people we have. We have 15 people on the call. Can we go into maybe 3 breakout rooms and just do a brief introduction, who you are, where you're from, your personal pronouns, and then ways you've participated in the Learning Collaborative previously, what you found valuable, and what we need to do moving forward. What I will do is post this into the chat once we go into the breakout rooms. And I will also post our goals so that folks can look at that. And the idea is to come back with an understanding of what we're missing, any changes, or saying this is good by us, let's do it.
Okay, so I have, yes?
I was just going to ask, are we good to go into breakout rooms?
Yeah, so 3 breakout rooms. I had created the 4 ahead of time, so if they're labeled, I hopefully it won't but it'll just be random assignments. So here we go.
Pause the recording. We do additional. Thanks, Francis. So we do additional breakout rooms. You should be able to have access to those questions now. So if you can type a few things into the chat that that you talked about in your breakout rooms about the work in the past, what we should be doing for our goals and activities based on our defined purpose, and we will capture that. Okay. So typically, this learning collaborative has focused on two key areas, one being education and one being advocacy. And so the intention throughout the next year of these learning collaborative meetings is to use the time for those two things, have a dedicated focus on each of those things during these quarterly meetings. And we can define what that looks like as a group. I have offered a framework for us to look at today and consider, again, with the intention of creating both personal and professional growth. But moving forward, we get to decide what we are going to use this time for. So I have put together some opportunities for us to discuss both education and advocacy, and I thought we could start with education today. And I'd love to hear folks just come off of mute and maybe think about and answer this question, because this is a question that I get all the time from a variety of audiences, which is why are we even talking about LGBTQIA people and their oral health? The most common response that I hear is, I treat everybody the same. I don't even know why we would want to focus on that in particular. And so I'd love to hear feedback from the group whenever you have that question. What comes to mind as to why it should be a focus for oral health stakeholders when it comes to LGBTQIA plus people? So I'm actually going to stop sharing and then just feel free to popcorn any responses.
First thing that comes to mind is that they shouldn't be treating everybody the same. And if they are, then they're missing some special needs of different populations.
I would also share as a dentist that there are still, though it's better than it was 20 years ago, there are still dentists who are very hesitant when they have HIV positive patients in their chair, which is a little crazy when we use universal precautions. But even so, that's an important continued learning moment.
Then you go back to fear. A lot of, we should focus on them because we need to provide a safe space for people to get care. A lot of them don't get care because they're afraid of how they're going to be treated, how they're looked at. Just ignorant, there's a lot of things. So we should focus on providing, so if they're not going in because of how they're going to be treated, there's neglect on their oral health. So they have, maybe have poor oral health, and we need to make sure that they are able to get access.
I would offer one other thought that most people don't realize. I was the HIV project officer for Minnesota, and when they had their priority list, there were like 15 to 20 items, and there was only money for 10. I remember the year when oral health was number 11. It wasn't that it wasn't important, but housing, medication, other things took precedent for that moment in time. So oral health is not optional. It's a piece of the puzzle of overall oral health, but sometimes there aren't enough resources to go around. So we have to be diligent in just continuing to say it.
Did anything else percolate to the top for anybody?
I think the only thing I can think of is, I know I dropped the statistic earlier about being disabled and the crossover with the LGBTQIA community. There's also a much higher prevalence of mental health struggles in the LGBTQIA community, thus impacting your oral health. If you don't want to get out of bed, you're probably not going to brush your teeth. So having been there, it's a big overlap. So it's important that the providers understand and can be present in that moment with people.
Yeah, I agree with the historical trauma that the communities usually experience in accessing care would be a determinant to seek care from an oral health perspective, and just tying it into the oral systemic link and overall well-being and health, that clinicians still need some broad-based knowledge on how to have compassion and care. Yeah, so.
Wonderful. I also thought about this question, and it really mirrored everything that we heard today from all of you, and I appreciate your thoughtful responses. Some of the responses that this learning collaborative has provided whenever we get this question, both in open and more broadly among oral health stakeholders, is that this is part of whole person healthcare. That when you are providing personalized healthcare, that it involves understanding the lived experience of every person in front of you. One thing that I often talk about at AIDPH is that we can't expect people outside of oral health, stakeholders outside of oral health, to put the mouth back in the body if we as oral health providers and stakeholders are not putting the body back in oral health, and the reverse of that. That means that we have to understand the full spectrum of folks' lived experience and how that could be impacting their daily life, their routine, and their oral health needs and outcomes as a result of that lived experience. So all of these things everybody has already touched on, and I thought it could be an exercise that we do here today. Originally, I was thinking we could do this with breakout rooms, but I think it might be okay, just given the size of the group, that we instead maybe just talk all together about how we can message, educate, and amplify the voices of LGBTQIA people among these key audiences, these key target audiences. Now, we understand that the intention of having this extend past these target audiences, that there's a lot of applications that are probably not going to be captured in those target audiences. However, for the purposes of today's discussion, we thought that we could look at these 4 areas and answer some critical questions. So I'm going to actually direct folks to the chat and ask you to click on the link to the slides, because this was designed as maybe 4 breakout rooms, but given we're going to be talking about this all together, I will let the group decide what you'd like to do. So we can take one potential target audience and really workshop that and think through maybe some additional discussion, action items, et cetera, for that target audience. We could think broadly. And it's really kind of up to the group. What I'll do is I'll set us up, and then I'd love to hear from the group what your vote is, and you can put that in the chat. So among institutions and organizations, some of the things we can workshop are What are internal policies that organizations can use to improve LGBTQIA oral health? How can institutions create inclusive environments, and what training and education should be implemented in these spaces that would improve the oral health of LGBTQIA plus people or general health? Providers, what are some common gaps in the knowledge base, and how could we potentially fill that? How can providers create those safe spaces? What are we missing and not understanding that we could dive into? And what resources or training can providers access to improve their knowledge around LGBTQIA oral health? And then lastly, I'm thinking from a patient's perspective. I think that's lastly. No, it's not. Next to last. What are some unexpected or little known barriers that these patients may be facing when they seek oral health care? And how can we really empower patients to advocate for themselves when they come into these spaces to receive oral health care treatment, and creating a comfortable and inclusive space? And then lastly, policymakers, how can we focus on policy change? What do they need to know? What resources should we be making available as advocates? And how can we be thinking about LGBTQA oral health as kind of a health in all policies perspective to inform advocacy efforts? So I'm going to stop sharing, and I'm going to invite folks to vote in the chat as to if we want to workshop one of these. We want to think through all of the target audiences and just kind of brainstorm across the board more broadly. So think through either one target audience and what would that be, or a broader discussion with just stimulating those questions.
Annalise, can I have ask a question about the organization?
Yes.
Is that in general organizations? Is that dental organizations, vendors, or DSOs? Or am I thinking too deeply about what that would be?
I think it's up to how you'd like to interpret that. I was honestly thinking about it from the perspective of AIDPH and doing some self-reflection. How can my organization be more supportive of this, community? You can really interpret that how you'd like to.
So us first, okay, makes sense.
But I would say that Christine's thoughts for a later dive, other institutions, they're all connected.
Yeah.
One way or the other. So it's a really good thought as we move forward.
I had a thought too, and a question about like what other partners and stakeholders, might there be in these spaces? That could be a role this group could take on, is doing some identification and alignment and collaboration so that we're, working together.
I see two comments for identifying patients as a focus. And I'm just curious why you would identify the patient as a focus over the provider being the focus.
Chicken or egg?
For me personally, thinking about it, I know that as someone with a disability, I often have to advocate for myself in these settings. And I think that the easier first step would be giving patients resources to advocate for themselves, because it's a big systemic change that needs to shift and happen. But as Steve said, chicken or egg, both need to be taken care of. So
I like what you said, Christina, because what I was thinking, looking at the two, going, why would I choose one over the other? Well, if the patient understands what their needs are and can verbalize them and then advocate for them, then we better know what education a provider needs.
Yeah.
Rather than trying to educate a provider on things that we might not fully understand if we're not having that lived experience.
Yeah.
Maybe we can dive into that topic and do a full group deeper dive on talking about patient advocacy. And maybe there is crossover with providers, how providers can help in that advocacy and empowerment process, but also thinking through how we, as stakeholders and organizations who desire to be equitable in this space for this target population, how can we help to empower patients and give them the resources to work for themselves. And maybe part of that discussion is identifying the current issues that are preventing that from happening. One thing that I can share as I think about the experiences of my children who are both LGBTQIA identified, one of whom is transgender. I know that every time my youngest goes into the dentist office, I don't think it's ever happened where they've actually used the correct pronouns, even when I call in advance and say them, ask them to make a note in the record. It just never happens. And that's one really small change that, as an adult, I can advocate on behalf of my child. But as a practice, that really doesn't take a ton of effort to get that right. But also, how can we help patients kind of think through in advance, facilitating the least traumatic visit, the least traumatic experience? And are there any other current barriers that we're not thinking about? As a patient may come into a dental clinic, experiencing a disparity, a situation where they're not included or don't feel welcomed or don't feel like they belong. How could we identify those gaps to then think through how we would address it through empowering patient advocacy?
I'm sorry.
Go ahead. Nope, Steve, you go ahead.
I was just going to say, I would just remind us of the Kubler-Ross series of grief type thoughts. When someone is diagnosed with HIV, fear, there's an embarrassment, there is anger, there is a feeling of no one else has ever done this, even though that's not true. And to be able to take people where they're at, because especially providers who are busy, they just want to get to it. And sometimes it does take a while, even to the point of an HIV positive person disclosing that they're positive. Do they disclose just to the provider? Do they write it on the medical history? I practiced in hospitals where there was honest to God, in the military, a pink triangle on the outside of people's paper charts before we use electronic health records. And if that doesn't anchor back to Holocaust type thoughts, you understand why patients are hesitant. So the advocacy for patients, we have to really understand where they're at. And that fear, embarrassment, anger doesn't go away after a month. So Liz, thank you. You passing the baton to you.
Thank you. And I'm jumping a little bit on your chicken or egg comment here, but I can't help thinking when we're talking about patient advocacy and when we were talking before about practitioners and what they can be trained, and we're talking about disclosures, I just automatically think of practice management. There's so many public health conversations around intake forms and screenings, whether it be for have you experienced trauma, have you experienced sexual abuse, for postpartum depression screenings, and then practitioners and practices not actually having the systems or times in place to review that information and comment on it or use it appropriately to provide care at best, and at minimum not re-traumatize patients by ignoring that information or re-asking it in a different way because they haven't taken that information. That kind of ties into Annalise's point of making the call, putting it on the forms with something like pronouns, and then not actually putting it into place. So you know, and I think as patient experience that can go across the board, to Christina's point too. So the education for patient advocacy of what they can do to make their appointment experiences less painful, but there's also an opportunity there for not just provider training of what they need to do, but how do they systematically implement that on an operations, logistics, practice perspective so that information is getting used effectively and correctly.
I like what you had to say, Liz, and from as being a former practice manager and some of the things that I work with here at the Primary Care Association, one of the things that we're talking about is education across the entire spectrum of staffing, even to scripting some engagement that people can tailor obviously to their own delivery style, but would be, you know, good afternoon, it's nice to meet you. My name is Beth and my pronouns are she, her. You know, how should I address you? I mean, these are some of the things that were exampled. And if we're tasking people to engage in that way, you know, the likelihood that people are going to respond, you know, and give you their information is greater because they're feeling welcome to do so. But then obviously it needs to be noted, you know, and carried through to the appropriate places and not with, you know, a big, you know, pink triangle or whatever else it is that we're using to mark somebody, but just in ways and respectfully identifying things about the patient that impact their care and their comfort to receive care.
I was typing a response in the chat and I just figured I would actually say it. Beth, I really like what you brought up around modeling. And I'm wondering how we could even model as patients with our own oral health providers, not just providers, but going into an oral health provider and saying, like you said, Beth, you know, my name's Annalise, I use she, her pronouns, even as a patient, to say, that's the expectation that I'm setting with this provider, that they should be asking those questions and honoring that lived experience across the board. One thing to remember about inclusion is that we're not just asking about things like pronouns, et cetera, when we think somebody might be LGBTQIA, right? Sometimes that comes up in these discussions where we're only asking that of somebody that we think may be androgynous or have a gender expression that's not how we would have expected, but rather that this is a best practice across the board. Everybody who comes into the office should be provided that same experience and that kind of routine care. And so as patients, we can also model that to our provider, that this is the expectation that I have for oral health care delivery, regardless of whether or not I'm cisgender or transgender or gender expansive. This should be part of best practice care.
They can even be carried out in the form of name tags. You know, I mean, I hated it when my staff didn't wear the name tags that they were supposed to, because I'm terrible at remembering names. But, you know, when I receive care, I want to know who I'm dealing with. But that would go a long way in just having that consistently available and seen in different settings that, you know, Dr. Smith is he, him.
It's an interesting observation that as we identify advocacy for the patient, that we're also bridging it to how we can set up perhaps a system for the practices or for the providers. So I was just kind of noticing that one, and then it's kind of sliding over to the other, that perhaps the offices could do X. So, because the burden of advocacy always seems to fall on the patient. And so it's a level of, you know, just this, I keep on going back to the practice management, like Beth, you know, just some type of systematic processes that can be more ingrained to more in the language that they're used to bring in to implement operations and implement systems. So it's not, yeah, so just more aligned in what their the operation languaging. So that's keeps one coming up for me.
As
Annalise-
oh, go ahead, Grace.
Oh, thanks, Christina. Annalise, what's bubbling up for me is a little bit of the research piece of this whole story too. Like, what do we know as a learning collaborative? What can we learn from? And I know AIDPH is in that, space of trying to create, research that is translatable and actionable. So I don't know if you have anything for the group to consider in terms of, like, when we think about these target audiences and the needs and moving the needle, however we define we want it to move. What can we learn, from to guide our thinking?
That is such a great question. And one thing that comes to mind is, from our LGBTQIA Oral Health Week, there were so many resources that were gleaned in preparation for that week. And the bulk of this discussion is actually not recreating the wheel, at least how I interpret it, is not recreating the wheel about how do we understand LGBTQIA plus people, but it's rather about getting oral health stakeholders to think about this and implement it. Because we don't actually have to recreate the resources. They're out there. We just need people to use them. So I'm suggesting that the work that was culled through that particular campaign was really effective, but I'd also love to hear more from people, especially if you are an oral health provider, about where you feel like the gaps are in those resources, and what do you feel like you need to get to fill them.
So I can share, Annalise, as a provider. It comes down to me of the differentiation between dental and oral health. The dental stuff, procedure, I do with my fingers. And if I'm using universal precautions, that's great. Where everyone will be safe, we'll get the work done. Oral health is the bigger picture. And I think that's an area that not every dentist and oral health provider appreciates. They like to stay in their silo, in their lane, and don't bother me with these other things. But especially with our community, the other things actually play such an influential role, even with the current medicines, the fact that HIV can be a chronic disease. But I appreciate what Christina said, the mental health burdens that are often unrecognized and unrealized are things that we have to focus on. It's not just about addressing the symptom of an oral health, filling a cavity. It's the bigger picture that we have to constantly be reminded of as providers.
Christina, you were going to add something earlier. Is now a good time to still jump in on that thought?
Yeah, it wasn't about providers necessarily, but I can quickly, it was more of a self-reflection back on Beth's question about why patients first. I think my own personal lived experience is influencing that, because living in Louisiana, I cannot fathom certain doctor's offices putting pronouns on a form and not receiving some sort of awful pushback. And it shouldn't matter if they get that pushback, but people are just mean. And I think for me, I'm like, oh, it's just easier for me as a patient to handle it myself. So maybe that's an angle you have to consider, I guess, culturally with different areas, unfortunately.
Okay, well, I think we had some really important discussion around how we could facilitate patient advocacy and empower patients to feel like they can advocate for themselves, but also recognizing that LGBTQIA plus people have probably had to do that way too often. And so really the onus is on the provider and the system to make that space for them. I think it's all relevant conversation, and I really appreciate everybody approaching that as thoughtfully as we did. And so I'm going to move us into the next focus area for our time together, which is advocacy. And we can spend as much or as little time in this topic as we would like to. And just thinking through how we've tackled this in the past, with advocacy, we've done this a few different ways, just as a reminder. We have created actual toolkits for folks to do advocacy on policy for LGBTQIA plus people from the lens of total person health and ensuring that we are showing up for the full spectrum of lived experience and reducing poor health outcomes that are a result of oppression, systemic discrimination, stigmatization, etc. But there are lots of ways to interpret advocacy. And I want to be very cognizant of the things that we've done in the past around policy advocacy can feel traumatizing and daunting and not a place where people want to engage. And I think the note that I'd love to make here for this call is that if you are a cisgender straight person, that these are the ways that you can spend your privilege, meaning LGBTQIA plus people have to advocate for themselves as a means of existence. That is something that we talk about all the time in advocacy, is that it's not an option for instance, a transgender person to advocate for access to gender affirming healthcare. That's literally their ability to live and have a basic living existence. And sometimes saying that, you should be engaging in advocacy around those issues, or even just reminding the LGBTQIA plus community that policies are advancing that harm them deeply is very traumatizing. And so the ways that we can engage on this probably differ for your own lived experience. And also, if you don't identify as an LGBTQIA plus person and you instead identify as an advocate or an ally, where you should be spending your time is in the places where this doesn't impact you directly and you have the mental and cognitive ability to take this on, where it would traumatize even more an LGBTQIA plus person. This is something that I just really want to offer as an opportunity to engage in that work. So how we have done this in the past is amplifying action alerts around federal policy opportunities. This came up during our advocacy around the Equality Act, which ultimately did not pass, but the Respect for Marriage Act did pass. And we did a little bit of advocacy in there, but really, as it related to healthcare, the Equality Act was a place where we spent some time designing advocacy activities, and we could certainly revisit that, although I'm not sure the Equality Act is relevant anymore. There are federal policy action alerts that we can address. Most of them are defensive, meaning please don't pass these bills because they're harmful. There are very few opportunities right now that I'm aware of that are offensive, meaning pass this good bill because we really need this to expand, equity for LGBTQIA plus people. We've also done primers on how to advocate for inclusive policies. That can be on the organizational level, it can be state policy, it can be federal policy, but giving people the tools to do that advocacy is another activity we've done in the past. And then lastly, we've talked about webinars and policy topics. We've also circulated action alerts for particular states, but as anti-LGBTQ policy really started sweeping so many states so deeply and so broadly, we didn't have the capacity or bandwidth to actually keep up with that any longer. So that's something we did do in the past, and we really don't have the bandwidth to keep up with, unfortunately. So I did want to signal two different opportunities and tactics for advocacy. One is that Open is doing a Hill Day, and that if we wanted to, as a learning collaborative, advocate for some sort of policy tie-in for that Hill Day that I believe is going to be in October, we have the opportunity to do that. I know that we have some leadership on this call for the Hill Day. I think, Steve, you're one of them. And then I can also, just as the facilitator of this learning collaborative, say we have identified XYZ as part of an advocacy opportunity. No guarantees it would go anywhere, but there is a dedicated space for that to occur. And if the learning collaborative wanted to come up with a policy ask and fold it into what Open is doing as part of their Hill Day, we could. The other opportunity is to create sign-on letters. That can be for a variety of topics. These are really easy advocacy opportunities that typically don't require a ton of bandwidth, but they can really make a very visible show of support for LGBTQIA+ people. Something that we've done similarly was a pledge that we created during LGBTQIA Oral Health Week, which was a pledge for organizations to make intentional and deliberate supportive and inclusive spaces for LGBTQIA+ people. So we could work on that pledge, we could broaden it, create more support, or we could also tackle some policy activities. So popcorn responses, what resonates around this? Is this something we want to engage in? How would we engage in it? And if so, are there tactics that rise to the top that feels like the most accessible ways to engage in advocacy around LGBTQIA oral health?
So I'll offer a thought, and it's more of a comment in terms of, since we started with patients before, I do think the whole federal policy issue is very important. But I'm also thinking, how do we educate patients to advocate for themselves? If I'm the provider and I'm the person, whether, and we'll say not malicious, but I am somehow offensive or uncaring to a community member in the chair, how do they advocate for themselves? In terms of, hopefully I'm a provider that will listen, but the alternative is often, I'm just not going back to you. And that's not always a good thing too, because my behavior continues with other people. How do we help patients advocate for themselves in a manner that's constructive? I don't want to say saves face for the provider, but actually educates someone who is non-maliciously ignorant. So I just want to throw that into the mix here, because the grassroots element of advocacy, I think, is very important.
And the thought that occurs to me in response to that is, once again, some type of modeling or scripting, because it is intimidating and I had this prior to getting into oral health, I worked in oncology for years, and I don't know how many times a patient might be displeased with something and might tell me as a medical secretary at the time, but they wouldn't dare say it to the provider. And my direction to them was, they're human, they're here to take care of you, they need to hear you. And if you're not comfortable, then this isn't you, we need to do something about that. So my first thought is, how do we empower them to do that, and feel that they absolutely have the right? But sometimes people need to be educated on the fact that they have the right and how they can go about doing it in a way that would be received, because we're all people and we get feedback, especially if we are, in doing whatever our profession is, it could be taken as an insult, and that's, it needs to be a learning experience. I'm in Maine. And I have to say, this is so timely, because I had set up a webinar You know, and one of the challenges I have is engaging the dentists that are all very busy at the federally qualified health centers. And I was so excited, but I ended up having to cancel it because of lack of participation. But I had an executive director, you know, for our LGBTQ IA population coming to speak about just generality, you know, about the population and understanding what's taking place in Maine. And I even found a dentist that was part of the community. And as you know, she identifies as being part of the community and advocates. And I thought, how great, I can have a provider talk to the providers. I got no engagement. The only way I seem to be able to get some of these providers, and I don't want just the dentist, I want all of the staff, is if there's a CE tied dangle to it. You know, if you show up, there's a CE, and then they may not even come on camera because they're doing something else, but they're present so they get their CE. That's my challenge.
Yeah. Well, don't feel bad about that, Beth. Hi, Helene. But anyways, we had we promoted a symposium, all-day symposium. It was $75. They got 6 CE credits. I sent it out to, and I'm from Michigan. I sent that out to all registered hygienist assistants and dentists in the state. And we promoted the heck out of it. And I got 40 people. And that email went out. I mean, we sent out 3. Granted, maybe we now have to think about different ways to market, but it went out to over 10,000 people. And we got 40 people. And we had some great speakers too. It was actually a wonderful day. You know, it was a great session, but it was, I don't know if it's like you say, it's the topic that they're overwhelmed right now. They're so busy. Who knows? But it was a little bit distracting. So that's why I think in terms of the advocacy for patients might be a good way to, you know, how to go there and start there first, and versus then maybe they have to educate the provider on a one-to-one basis about who I am, what I'm, you know, why I need to be seen or something.
And I felt so horrible canceling that. And I'm thinking these 2 individuals probably, you know, they were very gracious about it. And I'm sure have experienced being shut out in many other occasions. And this was not at all. I mean, I see the value. How do we get other people to see the value?
And Chris, as I listen to you, as much as 40 doesn't seem like a good number, those are 40 people who heard. And it may be the situation where turning, you know, lemons into lemonade, you actually follow up with those 40 and encourage them in their local dental society meetings, in their staff meetings, especially if they're not the provider themselves, but to be able just to share, this is what I learned. It was a positive experience. And if nothing else, it's a follow-up that gives you encouragement. And for both Beth and Chris, you know, the alternatives are 2. We don't do it, or we set it up again. And maybe we just use a slightly different personal approach to invite people. But I do think sometimes we have to start small, even after 30 plus years that we've lived with the stigma of HIV and AIDS. And LBG, all of the initials, being one of them, and I still can't say them all. It's not, things are not in the past. They're in the present right now. And we're always moving forward in a positive manner. So I would just encourage you not to give up.
Yeah, I appreciate Beth's comments on patient scripting and perhaps support. And I am not an expert on all the resources that are out there currently. And what came up for me when during this last session was, is there a 5-step tool for patients to become members of their dental boards in their state?
I believe with the main board of dental practice there's a opening for a member of the public.
Right, so in the, LGBTQIA plus community, maybe that can be a communication or toolkit. So this is what you can advocate for getting on the board, if they have the passion in either oral systemic or the medical, because that would change some things on the grassroots level. And I'd throw that out on the providers as well.
Okay, well, I think this has been a really a high quality discussion. I feel like based on our path today and where we seem to feel the most engaged is that patient advocacy is a place we can dig into more broadly, that there probably aren't enough resources on how to empower patients in this space. And perhaps this is something that the group could think more critically about, or even look at resources that we could develop throughout this year to support that effort. So I appreciate that direction as the facilitator. And if that changes, feel free to let me know. But I will close this out for today and just signal that our next meeting is July 27th. There's a lot of time between then and now, because we are moving these meetings to quarterly. I am hoping that by the time we meet again, we can maybe ask a friend to come with us. I think this topic is really important. It feels really important to me, but I would really love to see more people here who can help engage in this really critical work. So if you can think of any ways to promote the work that we're doing in July, and that, if any communities come to mind to be able to recruit, please do that. And in between then and now is Pride Month. So traditionally, this Learning Collaborative does something around Pride Month. Last year, we actually did 2 really, they're called Take 20s. I think we did Take 30 with Open, which was a 30-minute presentation on a couple of topics. I think we actually did LGBTQIA Oral Health 101 and 102, something like that. So I would love to do that again this year if that's of interest. And I would also love to not present that if there are community members or leaders here who would be willing to serve in that space. Again, our intention here is to lead from behind and just really create the space for other leadership to come forward in this area. So we welcome and invite that to occur throughout the month of June. We will send out virtual communication about that. So please stay attuned to your email, and that way you can engage in those activities. And I think I already talked about interested in leading, so please let me know if that is of interest, but collaborate with us anytime. As I said, it doesn't really matter who shows up to these meetings one way or another. This is a deliberate area of focus for AIDPH, and it will remain a deliberate area of focus. So if there are things that we should be doing as an organization, if there are things that we can be promoting through Open, or if we can create more space throughout the broader oral health community on this topic, and you feel strongly about something that we need to be tackling, we want to hear from you. So please know that we are open to all of that. This is a focus area that is going to remain one of our core areas moving forward. So we welcome all collaboration in this space. And so with that, I will stop, and I will also just ask, is there anything that folks would like to add, either vocally or to the chat, before we sign off for today?
I just have one brief update. It's not pertinent pertains to this meeting, but it does pertain to your other area of focus at AIDPH. I just got an email today from Sarah Sherman from the Maine Bureau of Veterans Services, connecting me with two individuals that represent Senator King's office, wanting to know more about Veterans Oral Services.
Well, that is very exciting. You'll have to let me know if there's anything we can do to help support that, Beth.
Absolutely.
Both Kathleen and I put something in the chat about our local pride walks. And so that's something that, you know, we could all do and see, and, or, you know, that's one where to provide educational materials is be at a pride walk and just distribute things. So that's what we're planning. Our Lansing's, Michigan's is June 17th. So we will be out on June 17th.
Oh, that's fantastic.
And what I was gonna say, I put in the chat because I missed most, so I had to chat a lot now. Like Chris, my internet is not very happy today. Sometimes I think we have to look at advocacy as not focused on our focus, but where it should be included in policies like at APHA, various things like that, and other policies and practices and procedures. So that when there's a list of who this policy applies to or what the ask is, it's included there and becomes part of a bigger picture and shows that inclusion matters.
Yeah, I completely agree. And I think that's a really good thought to end this conversation on today. I appreciate everyone being here, lending your time, energy, and talents to this learning collaborative. And with that, I will see folks in July. I will see you sooner. Thank you, everyone.
Thank you.